Hello, we're back with Airway Management, Chapter 10, Part 2 of 4 parts. Airway emergencies, the management of them, includes artificial ventilations. Ventilation is the breathing of air or oxygen or providing breaths artificially. Artificial ventilations, also known as positive pressure ventilations or PPV, is the forcing of air or oxygen into the lungs when a patient has stopped breathing or has inadequate breathing. So our methods of artificial ventilation, and they're in this order: mouth to mask, two-person bag valve mask, which we'll mostly refer to as BVM. And the third option of artificial ventilation is one-person bag valve mask. And this is the only order that's accepted through American Heart Association, National Registry. So if the question reads, the preferred method of artificial ventilation is two-person, it goes mouth to mask, two-person bag valve mask, one-person bag valve mask. Here we have the pocket face mask. It's an easy device to use with a one-way valve that allows and aids in artificial ventilations. You breathe through the valve when the mask is placed over the patient's face, and it's the preferred device when you need an isolation barrier to prevent contact with the patient's bodily fluids. If used just exhaled air, the patient receives approximately 16% oxygen. That's what your exhaled air contains. If used with a supplemental oxygen attached, it increases approximately to 50% oxygen concentration. You're going to position yourself at the patient's head, open their airway, place the mask on the face, apply to the bridge of the nose, and then over the mouth. You're going to place your thumbs over the top of the mask, your index fingers over the bottom of the mask, and the other fingers lift the jaw. Lift the jaw, tilt the head back, squeeze the mask to the face to maintain seal. Give breaths through the one-way valve, and these are slow breaths over 1 to 2 seconds in the adult and 1.5 to 2 seconds in the child infant. After you've ventilated the patient for approximately 1 minute, attach supplemental oxygen at 15 liters a minute and return to ventilations. Here we have the different sizes of BVMs, bag valve mask, for adult, child, and pediatric. The bag valve mask, it's a handheld device with a face mask and self-refilling bag that can be squeezed to provide artificial ventilations to a patient. The bag valve mask can deliver air from the atmosphere, also known as room air, that contains 21% oxygen. Or if it's attached to 15 liters a minute of supplemental oxygen, we can deliver up to 99% oxygen. With the BVM, you will do what we call bag the patient. There's different sizes. The top largest BVM in the picture is the adult BVM, which holds about 1,500 milliliters of air. The next one is a child infant BVM, with different size mask. And the last one is a neonatal BVM used in a pre-hospital setting. So our procedure for bag valve mask: open the airway with the head tilt chin lift if no suspected trauma. You're going to select the correct size mask. The most difficult part of delivering a bag valve mask artificial ventilation is maintaining an adequate mask seal so air doesn't leak. You're going to position yourself behind the patient's head. You're going to attach the BVM, then use your ring and little finger to lift the chin and maintain the head tilt. You're going to attach oxygen at 15 liters a minute and have an assistant squeeze the bag once every 5 seconds and 3 seconds for an infant or child. It's difficult to maintain a good seal with one person. Therefore, it's recommended that an assistant maintain the mask while you bag the patient. The American Heart Association recommends a one-handed squeeze when ventilating with a bag valve mask. And as you can see by the picture, the EMT is actually pushing the bag against the left hand. He's not using both hands to squeeze the bag. He's using his right hand to push it against the left hand. American Heart Association recommends one-handed bag ventilation. Bag valve mask in trauma, same as for medical applications, except we use the jaw thrust technique. Do not use the head tilt chin lift method. You can also ventilate through a stoma or tracheostomy tube. A stoma is a permanent surgical opening in the neck through which the patient breathes. A trach or tracheostomy tube is a removable airway device in place after a patient's surgical tracheotomy. Many stoma patients have a weakened cough reflex and frequently experience respiratory distress or arrest because of occluded airway from thick secretions that block the stoma. So ventilating through a stoma, we're going to clear the secretions. You need to manually clear the secretions from the opening. Do not use the head tilt or jaw thrust on these patients. Leave their head in a neutral position. Use a pediatric size bag valve mask and seal around the stoma. Ventilate at the approximate rate adult versus child. And if you're unable to ventilate through the stoma, consider sealing the stoma and breathing through the mouth and nose. Seal around the mouth and nose because air may be going back out. So you want to seal off the mouth and nose when you're ventilating through the stoma because the air may be coming out the mouth and the nose. If you're unable to ventilate, we're going to suction the stoma. We're going to aspirate through the stoma. And then when we aspirate through the stoma, we're going to insert the tube about 3 to 5 inches to get all the mucus out. If your ventilations remain unsuccessful due to secretions, you will need to utilize soft tip suction tubing. You may need to apply around 3 milliliters of normal saline into the stoma to help loosen the secretions, and then insert the soft tip suction tubing. Suction rules are still going to apply, and we'll talk more about suction rules later. Some patients with tracheostomies don't breathe through their mouth and nose. They breathe through the hole in the neck. The tracheostomy mask covers the tracheotomy hole and has a strap that goes around the neck. This may not be available in an emergency setting, but you can improvise by using a face mask instead, placed at the tracheostomy hole. Talk about some signs. Remember, signs are what we see of inadequate artificial ventilation. When we're ventilating our patient, it doesn't matter what form of artificial ventilation we use. We must be able to determine if our ventilations are adequate. If the patient's chest does not rise and fall when we ventilate, that would be inadequate ventilation, a sign of inadequate ventilation. We don't want to overventilate or underventilate our patient. Adults, we're going to ventilate between 10 and 12 breaths a minute. Think of it as 1 breath every 5 to 6 seconds. Infant and children, 20 breaths per minute, about 1 every 3 seconds. Ideally, if our heart rate returns to normal, that's what we want to happen. If the heart rate does not return to normal, then we have inadequate ventilations. If the skin color remains poor, we're wanting the skin color to improve to pink. If the patient's level of consciousness does not improve, that's a sign of inadequate ventilations. We want the level of consciousness to improve to conscious, to alert, and oriented. So how can we fix some of these inadequate ventilations? First off, reposition the head. It's usually the most common problem, and you don't have the airway open appropriately. You need to check for seals and for air leaking from the sides of the mask. You need to check to see if your equipment has a problem. Maybe you have a bad BVM, no tubing. You haven't attached to the oxygen source. Check for blockages in the BVM or tubing. Maybe somebody's stepping on the tubing. We can also help a patient with rapid but inadequate ventilations. So what are we going to do if a patient's breathing but breathing too fast, or breathing fast but inadequately? Reassure your patient, give them confidence that you know what you're doing. Explain that you're going to assist their respirations. You're going to place your device and ensure an adequate seal. You're going to put the BVM over the patient's mouth that is breathing rapidly but with inadequate ventilations. Then you're going to ventilate the patient at their current rate. If they're breathing 42, 48 times a minute, you have to bag them at that rate. Our goal is to increase their volume of breaths, which will reduce their hypoxia. As you ventilate at their rate, they will gradually slow their rate as you improve their oxygenation. So we're bagging them at their rate, 48, 50 times a minute. They're not getting adequate volume. What we're doing is bagging them at their rate to increase their volume, which will then decrease their rate. This is the end of part 2 of 4 parts of airway management.